Right. All right. Well, we've now going to make a start. So it's a great pleasure to introduce Gila Sachs. Gila Sachs has had a very distinguished career, but behind the scenes, in that she's worked within the civil service and within government for many years. And it's a reflection of the respect with which she's held in those quarters, as well as within the people with whom she's been working in the outside world, that she's been appointed recently to what amounts to a very pivotal role in an area that is extremely challenging, but also is an area that's particularly of interest to virtually every doctor in the country. And in addition to which, of course, to virtually every other healthcare professional. Now, I'm going to hand over directly to her, and she's going to talk to us about putting health improvement and health disparities at the heart of government. Gila.
Thank you. Thank you very much, David, for this very kind invitation. And it's really great to have a chance to talk and to discuss, I hope, with a number of you on the call. Let me start by explain a little bit about me and my role, and what I hope we're going to do together this evening. So the first thing I should say is, as David says, I'm a civil servant. As I'll explain, I work in the Department for Health and Social Care. I'm very much treating this as an informal discussion and speaking in a personal capacity, not, as it were, formally on behalf of the government. And there may well be some things that I can't get into because they're kind of midway through, as we'll touch on. We're early stages in some aspects of the work I'm going to talk about today, but hopefully we will nonetheless be able to have an interesting discussion. What I hope we will be able to do this evening is talk a little bit about health improvement, prevention, and where public health in government is going. And what I would really like to do is make sure we spend a good part of the session. I would really like to hear from you. I don't know who's on the call. I don't know your backgrounds, but as David says, I think, and certainly my experience has been that the types of issues we are starting to work on in my bit of government are issues which have very, very wide-ranging relevance and resonance. And it's something where I'd really, really value your perspective, your advice as we get started with this new endeavour. So let me tell you a little bit about me and my role, and we will get started. So as David says, I'm a civil servant. I am, by way of caveat, I am not a health expert by background or training. I run a team of many health experts, and very privileged now to work under the leadership of the CMO. So there's lots of expertise around. My bit, my angle, my expertise, such that it is an experience, is more in how to get things done in government. How can we use best effect the various levers of government, the various ways it can work, and ways it can partner and enable others to work to get things done, and at the moment to get things done for health in particular. I've worked across various different areas of government, and came into health early on in COVID, when I at some speed joined the newly formed Test and Trace, where I ran testing strategy for some time. That experience, very, very challenging as it was, again, gave me the public health bug. So I spent much of the past year, which I'll tell you a little bit about, overseeing reforms to the national landscape for public health, the closure of PHE and the design and establishment of its successor bodies. And what I want to do is tell you a little bit about why we did that, how we did that, but then focus in particular on OHID, the Office for Health Improvement and Disparities, where I now work, and the challenges it is seeking to address. So it's in its, I think we're in month 3, we're still very early days into this part of our work. But what is the prevention, the health improvement, the health disparities landscape that we face as we get started in our work, and how are we proposing to approach some of those challenges? And then, as I said, it'd be great to get your advice, right? What if you were me, if you were us, where would you start? What would you be doing? So I'll get started. I'll get started on that, and then look forward to hearing from you as we go. So briefly, what's the context in which the work that the office and I, my team, are setting about doing. Why, when, how did we go about reforming public health? So just briefly, what's the background to all of this? Well, some of you may be more familiar than others of this history, but effectively the kind of starting point for this journey was a decision by the Prime Minister in the late summer of 2020 that the government would reform the core institutions that lead public health nationally. At that point, there was broadly a decision, which was then confirmed as we went through the journey, that the local structures of public health would largely stay the same, but the national regional structures would change. And we can talk more about this as of interest, but that was broadly driven by two factors: by the pandemic and the experience of the pandemic itself, what that highlighted, what that taught us, but also more broadly, how did that experience of COVID shine a light on the wider learning, the wider experience of public health over the prior decade. And in particular, overall driving this decision, driving these reforms, was the need to ensure that we had a public health system that was genuinely fit for the future. Now, what that means is and can and should be debated, contested, and indeed governments, countries all over the world have been and continue to look at whether their public health structures, systems, and capabilities will give them what they need in the future. So we certainly weren't alone in doing so. But broadly, what drove this? Well, this is horribly simplistic, simplifying a very, very complex set of experiences. But broadly, it was very, very clear, even in those relatively early days in the pandemic, that the need was stronger than ever, or was more evident than ever, that we would need to make sure we had systems that were vigilant to external threats at all times, but that couldn't only, if you like, take the form of conventional health protection activity, but we also in parallel needed to make sure that we were going further to prevent the underlying health conditions or health vulnerabilities that would impact how resilient or how vulnerable we were to those threats. And overlaying all of that, a strong growing sense, which we've obviously seen grow, much further in the year or so that's passed since, of just how vital, just how central health is for everything else, right? It was, I'm sure, evident to everyone on this call, but not necessarily evident day to day to many others, right? Just how much of everything we did, how our economy functioned, and so on, was dependent on our health. And so it was those two things. How do we make sure that our ability to be vigilant to and manage health threats was as strong as it would need to be in future? But how did we also strengthen our underlying health and therefore the resilience that we could have against those threats of whatever form they might take in future? That drove this decision that we needed a different public health landscape. We then, I'll spade and ins and outs, but we spent, it came to about a year designing and then establishing and supporting the transition of public health functions from Public Health England and NHS Test and Trace, which were our two kind of starter bodies, if you like, into 4 new homes. So the health protection functions transferred into what became the new UK Health Security Agency, already a very visible, very known organisation, of course, because of the role it's playing in the pandemic response. PHE's health improvement functions and a range of cross-system functions came into the department were established in the new Office for Health Improvement and Disparities, and that's what I'll tell you a bit more about as we go. And then the remaining functions, a range of healthcare public health functions and associated functions transferred into relevant parts of the NHS. And briefly, when doing all this, what were we trying to do? And you can judge us absolutely in time as to whether we were successful, but what was driving us? Overall, we wanted to make sure that the system we ended up with drove better and more equal public health outcomes for the future. So that, whatever options we considered, that had to be our fundamental test. And in doing so, and in particular doing so during a pandemic, which is not always the most straightforward time to entirely restructure your public health system, we had to try to do so in a way that did not disrupt or lose capability from the public health system. We wanted to do so, as I said, in ways which improved our ability to protect people from external threats to health, to increase the government's focus and ability to impact on health improvement and health inequalities, and to more deeply, and this is something we'll come on to because it's really, really core to the work that I and my team and many others are trying to do now, to more deeply embed prevention right across government and right across the NHS. And finally, to make sure that although what we were doing was taking one organisation, effectively Public Health England, and separating out many of its functions, we wanted to make sure that in doing so, we retained coherence across the system. We had a system that could work together effectively. So that's the context. But obviously that's just, that's words and process and structures, right? What problems really were we trying to solve? So as I said, OHID has been live since October. And during the process of deciding to set it up, designing it, creating it, and now helping it get to work, we've been making sure that not just our own teams, but our ministers and our many colleagues across government, across the wider system, take a fresh look at some of the core data points, the core facts, the core trends and developments that shape the landscape in which we need to act. What are the big challenges, the big problems, the big needs that should determine where we really focus our efforts and how we go about doing so. So I'm going to walk through a few slides, just kind of setting out the basic kind of data picture. I'm very conscious that much of this data is, I don't want to say contentious, but one could cut this, one can tell this story in different ways, could focus on different things. I won't pretend that this is like fully comprehensive, but what hopefully able to do is just give a high-level overview of some of the key factors that, as I say, are shaping our prioritization and the approach we're taking to our work as we go. And firstly, and again, there's probably very familiar to many of you, but in the UK, and indeed this is seen in much, not all, but much of the developed world, life expectancy is stalling, and healthy life expectancy potentially worse than that, even prior to COVID. And that is that's a very, very, very stark fact that drives and shapes pretty much everything else that we're trying to do. In particular, the importance of looking at both of those things together to make sure that as government and as the health system and the many, many partners with whom we work, that we're not simply focusing on life expectancy, where a lot of focus for very good reason has been for various periods in the past, but focusing much more over time on healthy life expectancy, on what it really means to enable people to live more of their lives in good health, with greater independence, with greater autonomy. And so while this stalling and potentially these declines in some areas are not unique to the UK, we understand to a reasonable degree what are the various factors driving this, and as a result, absolutely cannot and won't slip into accepting this as in any way inevitable. So why is life expectancy and healthy life expectancy waning or stalling, and what can we do about it is really the thing that shapes everything else. And more than that, right, we know that sorry, my screen's gone a bit funny. Sitting beneath that headline, those headline figures, are a wide range of, and again, there are many ways of telling this story. These are just a couple, right? But a wide range of very, very stark and very troubling disparities. Some of these are very, very long-standing. A number of you might have, in different ways, heard or seen this. The CMO and many others as well. The CMO speaks very powerfully and has written powerfully about the fact that the basic geography of health in the UK remains almost, there are some exceptions to this, but almost unchanged in well over 100 years, and possibly quite a bit more than that. So some of these disparities are well trodden, very sadly. Others more dynamic. But just as example, right, we know, and it's something that very much drives thinking inside the department, is very high up priority list for our current Secretary of State, for example, that the fact that between the most deprived and least deprived decile, I brought figures here for women because they're starker, but the gaps, again, not just in life expectancy, but in healthy life expectancy are fairly extraordinary. A 20-year gap in the number of years spent in good health. And again, just thinking through what that means, right? So that how we will expect for I'd imagine any of us, how we might expect to live in our 70s and 80s, in reasonably sizable parts of the population, people are experiencing in their 50s, right? A pretty extraordinary position to find ourselves in today. So disparities by deprivation, by income, by socioeconomic background, disparities by geography, of which there are many correlations, but not perfect correlation between those two things, and certainly a range, although certainly not uniform, but a range of disparities by ethnicity as well. It's a particularly complex area because, again, there are some aspects of health where non-white groups do better, and the causes and ways in which ethnic disparities manifest themselves are quite varied, but certainly those disparities are very evident, are wide-ranging, and are very, very concerning. So an overall picture of healthy life expectancy not going in the right direction, underpinned by some very, very significant inequalities in how that picture is playing out. And what's causing this, right? What are we actually seeing take place? Well, a number, when you start to break down what we understand is driving variation in health outcomes, right? You are hit by some very, very stark facts, right? We know that various kind of ONS assessments and assessments of many others, that a pretty high, and the example given here is from an ONS study, that 23% of deaths in 2019 were avoidable, so could have been prevented through effective public health interventions or through much more effective early treatment and diagnosis. So a high proportion of deaths are avoidable. And then the kind of the spend, the impact, the way in which it's playing out on health care is very, very, very hard to reliably estimate. But a range of estimates have suggested that up to 40% of healthcare provision is used to manage preventable conditions. And certainly, as our understanding grows of what's driving cardiovascular disease, cancer, very clearly, growing conditions such as diabetes, right? It's quite evident just the extent to which health services are being focused on things that in many cases could be prevented. And yet the proportion of health spending in the UK going on prevention, again, that can be defined in very different ways. So I didn't put a number because it's quite contested, but by any estimate remains small as a proportion of the overall spend on health and care services. And the picture of what really is driving this, which conditions, which behaviours, fairly clear. So we know that cardiovascular disease and cancer is the leading cause of premature death. We know that musculoskeletal conditions and mental health conditions are the most significant causes of disability, and in particular play a very, very significant role in absence from the workplace. And that the modifiable risk factors, the behavioural factors that contribute to years of life lost or years lost for disability, again, remain very constant, remain reasonably constant over time, over population group, and so on. So tobacco continues to account for the biggest share of premature death and is a major factor, a major driver of health inequalities. That obesity, and certainly if you add together the range of diet-related factors, contribute very, very significantly to disability, and potentially for up to half of all years of life lost prematurely due to modifiable factors, right? So if we could get after tobacco further, we could potentially very significantly help to narrow health inequalities, particularly in terms of overall life expectancy. And if we could go a lot further on diet, then potentially very wide-ranging implications for much of the population, and much, much more widespread issue. And then when you get into some issues which in and of themselves are of a smaller scale, but the harm falls disproportionately on particular groups, on the young and on the poor, alcohol and drug use, of course, continue to be very dominant. So what do these things tell us about what we should do? Well, as I said, the interesting thing is that the pattern stays the same, right? So whether you're looking at the richest or poorest areas or groups and so on, you may well and certainly would need to intervene differently, but the prioritization, the scale of the impact you would be seeking to have is very consistent across those groups. And so broadly, when we look at this, we see that if we can really focus on improving early detection and effective early treatment of these key conditions, we've given examples here again of cancer and CVD, of MSK and of mental health, that a strong focus on diagnosis, on detection, on management and prevention there could yield fast and very direct impact. But if you want to really impact over the long term, if you want to sustain that impact, you need to additionally go for the underlying drivers. In this case, again, pulled out diet and smoking. And it's very clear to us that we need to make sure we're able to operate on both those levels. So we need to be strengthening diagnosis, detection, secondary prevention where those risks are in play. But we can't only do that. We'll be fighting a losing battle if we don't go for those primary risk factors that we know drive not just these health conditions, but their wider societal, economic and wider implications. And we also know that COVID has had mixed but overall negative impacts across many of these behaviours, and certainly across the disparities, the ways in which they're playing out. Now, of course, we're looking quite hard at how some of these trends are changing. COVID is still very much a moving feast, right? And it is in some areas too early to draw firm conclusions about which of the trends we've seen during COVID will last and for whom. But broadly, we know that, right, certain populations experience much greater mortality levels, certain groups continue to have lower vaccination rates. We know that a range of unhealthy behaviours increased during COVID, and even at times when we came out of lockdown or COVID rates came down, in some cases, those unhealthy behaviours did not follow. For example, we've seen fairly extraordinary increases over the last 2 years in levels of childhood obesity and behaviours towards shopping and consumption and so on, not returning yet to pre-COVID levels. So some very significant COVID-related concerns. And worth saying, there is an upside. Maybe we'll touch on this in a moment, but there is a lot COVID related to be very concerned about. There is an upside too, right? And a strong sense, I think, that the growing awareness and focus across a much wider part of the population on health and what it really means to them does create an opportunity and a very burning need for us to tackle some of these risks and disparities. And when looking at this context, as I said, when OHID sets to work and sees these challenges ahead of itself, we are very mindful of the fact, which again will not be a surprise to people on this call, but is not to be taken for granted in terms of the way decisions across some aspects of government or the health system have always been taken, but the need to recognise and act across the spectrum of levers and influences which we know shape health. So there have certainly been times in the past when health policy and health service provision has been very focused on services, right, with the kind of implicit assumption that better health services will drive better health. And while to some extent that is self-evidently true, we know that our health is shaped by a lot more than that. It isn't random, and it isn't only about the services we receive. It's about quite a lot of other things in between. The choices we make, the conditions in which we live, the genes we inherit, and so on. And again, there are very wide-ranging, very wide-ranging, there are many estimates of exactly what proportion of health outcomes could be attributed to what, but many and probably most agree that over half of the burden of poor health can be attributed to these wider factors, the wider determinants, social, environmental, economic, and so on, which drive health outcomes. And what that means is that we know that we have to act across this pyramid. One can draw it in lots of different ways, right? We have to act on the conditions themselves. As I said, if we want to make direct and rapid progress, right, we have to go for the things which we know are preventable and can be diagnosed and can be treated, of which, of course, CVD, cancer, and so on are remain enormous priorities for us and our partners across the system. But we can't stop there. We need to also act on the biggest behavioural risk factors and on the social environmental determinants. And there has been good example, good work across each of these areas, and a lot more we hope to come. So, of course, some fantastic progress. These are just examples. One could choose many, but on the, of course, on early detection of cancer, on clinical management of various cardiovascular risks, and so on. Some very, very important progress across the major behavioural risks. So, for example, work to stimulate reformulation in food, work to improve and make it easier to stop smoking, and so on. And of course, a very, very wide range of improvements over the last century in health have, of course, come from improvements in working conditions, in housing quality and air quality, and so on. And it's when we can look and act across that spectrum with a consistent seriousness of intent that we think we really be able to make lasting change. Some of these things take a lot longer, some of them require very different levers, but we need to be able to act across each if we're going to make these changes particularly last for the people who are at most at risk of not benefiting or being excluded from any of these improvements. And so finally, before we talk a little bit about OHID itself, and then want to hear from you, there are many, many ways of describing why this matters. And I'm sort of slightly hesitant about whether to include this slide, but it is important. It's important in the way we're thinking about this at the moment in government, with a levelling up mindset that it goes without saying, and it will be true not simply for the health and care workforce, but of course everyone who benefits from it. What the individual and collective consequences are of not tackling some of these, I think, very, very worrying facts that we've looked at over the last few minutes. But we also know that the costs to the economy, the cost to the country of not turning the tide on preventable ill health and not working further upstream to manage health demand, we know will be very, very widespread. So the costs for the NHS and for the social care system, if we can't reverse some of these trends, if we can't take more assertive and consistent action on preventable conditions, we know will be very, very, very considerable, as we are seeing in the UK and across much of the world. But also the wider economic impacts, the wider productivity losses. And these are just some examples. And in particular, really, really important for us to make sure that not just in our work, but in the work we do across many, many other parts of government and their partners, that we're able to really make this argument that this isn't simply about supporting individuals, though of course that should and will continue to be top of everyone's priority, but that if we really want the country to be a more equal place, and if we want the NHS and social care systems to be sustainable, we have to tackle these trends and the underlying inequalities which sit underneath them. So let me tell you a little bit about how OHID, the Office for Health Improvement and Disparities, is setting about trying to take on these challenges, and then let me ask you a few questions at the end of that. So what is OHID? I know it's not the most catchy name, the Office of Health Improvement and Disparities. One of the joys of organisational change and establishment in government, it's something that everyone gets very interested in, is naming. And this is what we settled on, as certainly our Secretary of State, our previous one, our current one, really wanting to emphasise the challenges and the need to look hand in hand at the improvement challenge and the Disparities Challenge. So what is it? It's a multidisciplinary unit in the Department of Health and Social Care. And that's very important. I'll spare you the slightly painful history of trying to work out exactly how we should bring this organisation together. But we thought hard about whether these problems, these challenges should sit in the department, or should they, as PHE was, as the UK Health Security Agency is, and various other partners, should it be slightly more arm's length? Should it be an agency of the department, an arm's length body? We decided no, right? The nature of the issues that I've just summarised very, very briefly can only be tackled right at the heart of government, because they depend both on the health and care system, the NHS, local government, and so on, but also on the actions of many, many, many other parts of government, the education system, the work and pension system, housing, transport, and so on. And so we took the decision to bring these issues, to bring health improvement right back into the centre of government, and to create the office inside the department, and to do so, bringing together different disciplines. So we brought together public health expertise, analytical and data expertise, together with policy people and with people that drive and support the system to deliver, to implement, and brought all those things together into one entity, so that we were able to pull that thinking, pull that expertise in new ways, and in doing so, be better able to influence decision making within the department and within the health system much more widely. And it's been a major shift for the department. We have gone from having a single directorate, so maybe, I don't know, 130 people maybe work on public health, to now having effectively 10 times that. We now have about a third, it's a little bit hard because COVID numbers change all the time, but about a third of the Department of Health and Social Care are now working on public health, a huge shift from a department which for many years was very, very focused on the NHS in sort of narrower terms, and now has what I think is a really exciting opportunity to think about health much, much, much more broadly, and not just about the health service and health system. We sit under the leadership of the Chief Medical Officer, which is fantastic. It's an enormous privilege, I think, for many of us, and really recognise that we have an opportunity to use his expertise, and particularly, at the moment, his kind of very, very powerful position he holds, together with the very focused leadership of our Secretary of State and ministerial team, and to bring those two things together to be driving action in this space. And what's our mission? To improve the nation's health, so everyone can expect to live more of life in good health, and to level up health disparities so that we break the links between background and people's prospects of a healthy life. And we do, I won't go into detail, we are developing our ways of working, right? How are we going to do this? How are we going to make the most of this opportunity we think we have now? And just a couple of examples of this, we are very, very focused on making sure that we are outward looking and partnership building. Again, the nature of these issues means they clearly can't be solved by a government department on its own, but they also can't be solved only through working with health partners, right? We need to be able to work effectively across the health and care system, and again, in particular with strong links both to the NHS and to local government, and be able to hold both of those in tandem very, very, very carefully, but also work with a much wider set of partners in academia and industry, and instead across sectors and across government, because of the nature of the causes, if you like, that drive public health challenges, but also because of where we believe innovation can and should lie in terms of what they will take to solve. And we do that, as I said, partly through the range of disciplines that we bring together, but also, interestingly for us, because it's quite new for the department, by making sure that we have a regional presence alongside our national presence. So whereas the department has in recent times been kind of solely a national entity, we have brought in the regional public health leadership into the department, enabling us to have a much stronger, more active two-way link out into the system at local level to help drive and shape our work. And what are our objectives as we set to work? Well, as I've touched on, to really starting with the need to identify and address health disparities, to take hopefully bold, new, brave action on the biggest preventable risk factors, to work with the NHS and with local government to improve access to those services which detect and act on health risks, whether that's in terms of screening or cardiovascular management, health checks and so on, to develop those strong partnerships, as I touched on, so that we can act not just on the health condition or the behavioural risk, but on those wider determinants which play such a huge role in health. And as I said, to drive innovation and change, so that can we try to be a place that can partner with, can harness, can bring together the best of, whether it's in terms of data analytics, delivery innovation and so on, so that we can take on some of these challenges which are, as we've seen, quite deeply rooted, quite long-standing, and find new ways through. So finally, what does that all amount to? What are we actually spending our time doing? Well, these are just a few. This is not a fully comprehensive list, but what are I and my teams and my colleagues spending our time worrying about? Well, we're spending quite a lot of time thinking about how we can mainstream public health. And as I said, this was one of, well, certainly what kind of drove me to try to push for bringing these functions back into the department, and really drives a lot of where I see OHID's potential and its added value, right? Can we go from what I think a reality where, I mean, certainly pre-COVID, and COVID has changed a lot, but public health can often be a little bit on the margins. The big focus, the big money, the big politics, the big energy can often go into what is considered to be the core health service and health system, and public health was somewhere doing very important work, but a bit over there, and we need to change that. And I think the arguments for why and the cost of not changing that are pretty evident now. We need to put prevention, put disparities right at the heart of health reform, of what it means for the department and our many partners in and around the NHS to think about what it's going to take to strengthen, to improve health delivery. Prevention can't be a separate thing. It has to be right at the heart of that. Secondly, how can we ensure a positive legacy from COVID? Right, we know, as I said, that COVID is impacting on attitudes, on behaviours towards health in all sorts of ways. But we also know that there is some really positive learning that we could do. Right, we've seen fantastic engagement and innovation in terms of what it takes to reach out to harder to engage groups, whether for vaccines or testing and so on. A lot of learning, I think, on communications, on how governments communicate, on how health systems communicate. Certainly quite extraordinary kind of pace of progress on digital. That I think we now have more than half the population using the NHS app. Well, that's a huge opportunity, right? What do we do with that? So a big focus for us to try to work out how we can really seize on that learning and do so quickly, right? Do so while that learning is fresh and that moment is hot. As I said, we are looking deeply at health disparities, trying to shed some new light on some of these old trends, and again to make sure that we do so right across the prevention journey, right? So are we thinking about disparities end to end, right, from those wider social economic drivers right the way through to disparities in the ways in which people are accessing services, are receiving treatment and so on. Where are things falling through the gaps? Why? Who is getting that right? And how can we drive consistency there? As I said, lots of this comes down to this big challenge, which I'd love your views on how we can put prevention more firmly at the heart of the NHS, mindful of the pressures on the NHS, right? This, again, if prevention is an add-on, now is probably the worst time to try to add anything on to what the NHS is trying to do. So how do we make sure it isn't that? Right? How do we make sure that as the NHS manages the pandemic, as it manages the huge challenges of the electives backlog and so on. And as it reforms itself, including through the development of integrated care systems and so on, right, what opportunities does that present for prevention? And alongside the NHS, how can we better support local public health systems? Where again, I think there's been really, really fascinating to see the ways in which local directors of public health and their teams have well, the role that they've played, and also the kind of space and authority they've had during COVID, right? What next, right? I think that the role of the DPH has changed fundamentally. And there's a big question both at local level and potentially at national level as well about what that means, how we can really make the most out of that shift. I'll stop. I'll do some of these very briefly, but we're really, really interested in the question of how we can think about prevention more holistically. So at the moment, we do lots of things in isolation, right? You might go and access a weight management service, but it's not talking to your screening offer, and it's not talking to your, when you go and see your GP about X or Y other condition, right? These things are often, not always, quite fragmented. How can we join that up better? We've just launched a new ministerial committee on health promotion. The Prime Minister chaired the first meeting of that in December. A big opportunity, only one of hopefully many, but a big opportunity for us to strengthen cross-government action on health. And as I said, very, very keen to take a fresh look at how we approach some of these risks, and critically who can help us do so. So some questions for you, and then we'll stop screen sharing because at the moment I can't see or hear or anybody or any questions or any hands. But a few questions for you. Obviously, I'm very, very happy to take any wider reflections or questions for me as well. But these were a couple of things which I thought you might be able to help me and my colleagues with. So given your, I'm sure, very, very rich, very varied experience of the health system, I guess my overall question is, what do you think should be top of our to-do list, right? There's a lot to do. Where would you start? Who should we be learning from? So which health systems, big or small, right? Do you think, or have you seen, are the most effective at really driving prevention and tackling disparities, right? These challenges are not unique to us. Many, many people are trying, many are struggling, and some are succeeding in these challenges. Who should we be looking to and learning from? How, especially in the current context, right, where should we start? Where do you see the key opportunities to strengthen the role of the NHS in prevention? But potentially, for example, through the role of the wider health workforce, right? So we already are some way on the journey, but I think have a lot further to go to enable lots and lots of parts of the health workforce to see themselves as playing a role in health improvement, and that not just being a public health thing. And then finally, how can we, as I said, best ensure a positive public health legacy from COVID? So let me pause there. And would love to hear your reflections on some of these questions or more widely, and any advice you are willing to give would be gratefully received as we, as I said, kind of early days as we get started on this next phase of our public health journey.
Right, thank you very much. And you can't see the questions. I've been trying to cluster them into. We've had more than I can remember for a long time, and and you've got an audience of some very eminent colleagues who feel that this has been a tour de force of presentation and really has stimulated a huge amount of interest. So let's start off. There are a couple of questions about here and now. Despite all this, the NHS so-called not coping, what you feel about the 6 million people on waiting lists, and the big crisis of the moment relates to vaccination rates amongst those who we're calling for the moment disparities. There are questions about that question later. Do you have any comments on those two issues?
Sure. I mean, and as I said, very much kind of speaking in a personal capacity rather than anything more than that. I think, as I said, I think, and indeed was having various discussions with colleagues in other parts of the system about this only today, that actually, there clearly are immense challenges to the system in terms of the scale of the waiting list as you've described. And there's there's no way around that, right? That's going to take enormous amount of work, a lot of investment. Investment obviously is planned to increase significantly to help to tackle that. But it would be a wasted opportunity, I think, if we didn't think and didn't try to think creatively about what we do, how we can best support those people. So I hope that the challenge won't only be how do we clear that backlog as quickly as we can. We should certainly try to do that. But that should be, and I think absolutely there's a lot of work in hand to make sure it is, a driver of innovation, both in terms of the delivery of the specific service, right? So there's obviously a lot of work, many of you might be familiar with, in terms of trying to look at innovative delivery models on diagnostics, new spaces outside of kind of mainstream clinical settings and so on, in which some of these services could be provided and so on. So I'm hopeful it is a driver for innovation in delivery, but also I think prevention in its broader sense could have a big role to play. How do you support people? If people are waiting for a particular treatment for a longer period of time, they should be a key kind of target audience for some of the kind of public health and prevention interventions, which we've sort of touched on briefly here. So, are there things we can do to, if someone's waiting for a hip or knee replacement, for example, what can we do to support them during that period to lose weight, to improve their health, so that when they get to their treatment, they are best able for it to go well, for them to recover well, and so on. But also, how do we use some of these interventions and what we understand about them to reduce the flow on to the list, right? So it is, certainly an enormous challenge, but I hope it's an opportunity for some different thinking as well. And as I said, there's quite a lot of appetite, I think, for doing that. In terms of vaccine hesitancy, look, all I can say is that, one of the things, I think we've been really kind of privileged to see over the last year, or I suppose the last year, has been that this challenge, right? How do you really find new ways to communicate, new ways to reach out? It has been, I think, has brought out some of the absolute kind of best practice in public health that the system has seen for a long time. Right? There's been some really exceptional work at community level, at local public health level, and nationally, which I think for many people with long public health histories is not rocket science, right? The idea that you really need to start from where people are at, that you need to understand which voices they will trust, that you need to go to spaces and work and talk in ways which resonate with their real concerns, that you need to adapt and flex and tailor your approaches and not expect people to come to you, speak your language, and so on. Those are all things which, in principle, we should all know and we should all have known. And yet this challenge and the urgency with which it's been treated, I think, has given those issues a much wider platform. I think one of the jobs for us now is, that shouldn't be the end of it. Right? I've had various public health colleagues say to me, one of the challenges they face is they go to some of these particular groups or communities to try to persuade them to take a vaccine. And the response they get is, well, it's the first time we've heard from you, and now you're going to go away. Like, you didn't come when we needed X, Y, and Z. You come now because you want us to do this, and we're never going to hear from you again. And we can't have that, right? This has to be the start of a new way of engaging. If we've got someone to take the COVID vaccine, what about the next set of vaccines, right? What about screening? What about diabetes prevention? How are we using community champions, community networks, and so on for these wider health objectives? So I think, whilst I wouldn't want to in any way kind of play down the challenge of vaccine hesitancy and vaccine uptake overall, I think there really is some fantastic foundations being laid through this process, which should stand us in good stead.
One issue that raises is the fact that when your introductory remarks, you refer to the fact that early detection, screening, and immunization are actually outside the umbrella, to a certain extent, of the new office.
So their delivery. Oh, interesting. So so their delivery of them is, but the policy is largely within. So it's a bit mixed. Screening sits in my team, a screening policy. Health checks sit with us. Immunizations sit with the UK Health Security Agency. So there's a bit of a split about, are you detecting something or are you preventing it? But in lots of those areas, we work very closely together, and the NHSCI teams do the delivery. So yeah, it can get a little bit messy, but hopefully reasonably joined up as well.
Because Dr. Leora Harvard, who's a general practitioner, raised the question that GPs often know what the right thing would be for their patients, but they're not always part of the decision-making process, so they can't get the access to the resources they need. And they also notice that the implications of not getting the access can be serious in terms of healthcare provision, and the social consequences of people with musculoskeletal disease don't get the treatment, therefore they're out of work, therefore other factors supervene. I mean, how do you tell, is that part of your remit?
I don't know if we can bring in whoever else, but I would really love views on particularly kind of that question. I think there is a lot of recognition of the central role that GPs and primary care can and should and wants to, I think in many cases, play in this space. Quite mixed views in the conversations I've had about what the solution to that is. Do you know what I mean? Where does it fall down? And is it a kind of fundamental question about, like, there's simply not enough of the things you need out there? Do you know what I mean? So you refer people, but there are a long waiting list and so on. Is it that the referral pathways are very clunky, right? It's simply not easy enough for a GP to be able to join those services up effectively for the individual. I mean, so anyway, I'd love any view, kind of more, yeah, I'd love views from others on that. It's definitely a big part of what we are looking at. I think the thing I'm nervous about is there is a risk of just layering more and more and more on the GP. And it's a very, very, very stretched system. So I think, we're very interested in how can GPs work, even more effectively across and alongside other parts of the system. So, for example, there's obviously quite a lot of work that's gone on, continues to go on what can community pharmacy do, right? Which aspects of some of what we've been describing can pharmacy play a role in? Which other kind of community-facing services could work alongside the GP so that the GP is really able to do the things which only it can do, which we know people really respond to a GP on much, much better than others. But we're able to kind of not overburden that part of the system at the expense of others. So I think it's, a big, big priority, but quite a difficult area, certainly.
One of our distinguished general practitioners raised some other aspects of it. I'm going to come back to the questions we were talking about then, but raise some other aspects of it. Does this mean that you're going to make sure that the DHSC is not going to be opposing further taxes on obesity, sugar? They're not going to allow as many licenses for fast food restaurants to be opened, and unhealthy foods will be kept off the agenda. He also raises the question that prevention costs money. And have you persuaded the Treasury that they're going to have to take a long view on your budget? They're not going to take a short-term view. And related to that, one of our distinguished public health doctors, Dr. Sim, raised the question as to whether any CEO has head has rolled because of failure to implement public health interventions. So
okay, so these are great questions. Sadly, I'm not in charge of all of this, and sadly, actually, nor is the Department of Health on its own. So quite a big part of, as I said, one of the big reasons to do it this way is because we know, to change taxation, to change regulation, whether it's on food, food formulation and labeling, whether it's on planning, who does or doesn't permit fast food outlets to open near schools and so on all of those issues, we need the backing, we need the support of the Prime Minister, of the Chancellor, and of cabinet colleagues, and those things are all in different ways under very, very active discussion at the moment. There is and many of those debates you'll have seen playing out, right? There is but they are certainly very, very active debates, and we, our ministers and so on, looking closely at, what did we learn through, for example, the sugar levy, which is widely seen to be been very, very effective. Where for which products and in what ways can that kind of model work effectively, and not which other, what have we learned from other countries, and so on. And similarly, in terms of some of the planning issues, where actually it varies, but local government has quite a lot of leeway in this space. already, and some local areas are already demonstrating that, right? So have already been able to take some quite difficult choices in this space without, as it were, needing kind of recourse to central government. So they are very, very active issues. I can't say much more than that at this point in time. On the question of the Treasury, yeah, it's quite a big part of my to-do list to try to work through. Let's put it like this. My concern is, coming relatively new, as I said, relatively speaking, to kind of public health world, is that I sometimes worry that, and I'm about to offend about many people, hopefully not many people on this call, but I'm sure many people, that sometimes things are so self-evident that you think if you kind of say it enough times, other people will eventually agree with you. And that kind of hasn't proved to be true, right? So it is kind of so self-evident that if you invest in prevention, you will save money. If you do it properly, right, you'll save money down the line, that we just kind of keep saying it, hoping that at some point someone will listen. And we can't do that anymore. We have to find different ways through. Certainly it's something that our kind of, let's say, relatively new Secretary of State is very focused on. How can we make the economic argument for health in different ways that will resonate with different partners? And I'm very keen that I'm trying to make sure that we don't just try and persuade the Treasury of this, but if you like, we kind of really bring them into the tent, and not just the Treasury, but their wider partners, the ONS, the OBR, the various agencies that help to define what counts as public spending, what counts as investment, what counts as risk. We need those various partners, let's say, kind of in the tent and really able to help us understand what kinds of changes, what kind of evidence will they need to see in order to believe what, again, appears self-evident and yet too often isn't so. So it's, yeah, it is absolutely a big part of the work plan, but many people have tried, and I won't underestimate the challenge that's going to involve.
There are two questions from Dr. Sim and from Dr. Penny Toff, who are both public health experts. And Dr. Sim raises the question that this is tackling the causes of causes, is what Sir Michael Marmot has been saying for a number of years. One wonders whether he has any words of wisdom to offer you in this regard. But poverty at the early years is the core. Other people have raised the question, are you renegotiating not only with the Treasury, but with the educational system, because it requires education of children? And the worry is that the dispersed organizational structure, as you outlined it, how is this one going to be more successful? In parallel, John Grabner raises the question that the health service really, that you have to take on board, that you always need the service working at less than full capacity in order to cope with full capacity when it arises. And that's another question that can you persuade the Treasury to take on board? Penny raises the question that it's not in restoring the value of local public health funding. It's also persuading how you're getting the new integrated care systems, which are in the bill going before the House of Lords at the moment. How are you going to persuade them that the public health agenda is actually important when there isn't even there used to be always a public health officer on the main local board? Have you not, or the department not asked for that status for public health within these new structures?
Okay, let me take those in reverse order. So ICSs, absolutely. So I couldn't agree more that getting kind of public health in its various ways, kind of mainstream, if you like, within ICSs, has to be a very, very central part of what we've just been discussing. There's a whole range of ways in which we're trying to do that. Firstly, and I'm slightly cautious about this because being completely honest, I can't exactly remember where this is up to in terms of various bits of guidance and paperwork and so on. But absolutely, our intent is that ICSs should have public health representation on their senior governance structures. I'm just slightly caught, I can't remember which bit of which structure, and it's kind of not directly my area, but absolutely that is the intent. And we are working very, very closely with, it's not directly my teams, but like my colleagues working very closely with both bits of the department and the NHS that are overseeing the passage of the bill and the development of ICS guidance and structures to absolutely to try to ensure that you have the right representation around the table, and more than that, right, that this is meaningful integration in ways which really can make it easier for systems. You know, the whole point of integration, right, is to be able to look in a more joined up, more holistic way at population health. Anyway, as I said, a range of ways in which we're trying to make that happen. One of which, and it's only one, is that when we kind of designed this new structure, we opted to have the regional directors of public health and their teams sit jointly across the department and the NHS, in particular for this reason. So we wanted to make sure that there was very senior public health leadership able to work closely, well, both as work kind of with us, so to be part of this work in this agenda, but to work closely and in a hands-on way with ICSs to support them in their development. So absolutely agree with it, that's a big priority. The question of whether the system can run at less than full capacity, I'll be very honest, I'm absolutely not placed or qualified to answer. It's not only is it a very complex, very live issue, it's not my area at all, and I won't attempt to. But suffice to say, you know, there are, well, it goes without saying, I hope that there are very, 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 very serious, very focused work going on across the department, Treasury, and the NHS to make sure that resilience is as good as it can be, and that, you know, maximum learning is undertaken through and as a result of this period. Marmot and the causative causes. Yes, we do speak to him. He is fascinating. He's very good at telling us when we are getting everything completely wrong, which is very welcome. And he obviously has done and continues to do an enormous amount to highlight and keep some of these challenges very, very high up the public policy agenda. We absolutely do work closely with the Department for Education and a wide range of others, as I said, in particular on early years, the early years agenda. It was great in the spending review. There was a commitment for big new investment in early years provision. That's something that DH and DFE are working on very closely together, and along with lots of other things, food in schools and so on and so on and so on. So we do work very closely with other departments. I won't pretend it's always easy, and I certainly wouldn't dare to suggest that this structure will solve all the kind of fragmentation problems of the past. But as I said, I hope it is, and I really do believe it's a step in a positive direction, right? It's PHE was many, many fantastic things and had extraordinary expertise, did a huge amount of good. But it was one thing it was very, very hard for PHE to do, was to really build those partnerships from a policy as well as a delivery level across government, influence what other ministers did as well as what our own ministers did, and so on, and make things happen across government. It's not easy to do, but I think we are better placed to do it now than we have been for some time. And as I said, I think the fact that the Prime Minister, you know, personally established, chairs a new cross-government ministerial committee at the highest levels on these very issues, it doesn't solve the problem, but I think it is a powerful signal of intent and recognition of just how cross-cutting these issues are.
I mean, we have some people who support us as philanthropists, and one of them has raised the question that you know, that given they recognise the problems, what about instead of the taxes on alcohol, tobacco, what about the reverse? What about providing tax rebates for those who improve their lifestyle? That their reward will not only be in the future, as it were, with a longer life, but their reward will be tangible.
So it's not quite the same. We are about to. This is interesting. We are about to pilot. This will divide opinion, right? Some people think this won't work at all. Some people think this is the fantastic answer to everything. We're about to pilot incentives. So we're going to work in a particular region and basically launch an app whereby people can log their their eating behaviors, their exercise. They'll get a wearable device that helps them do that. And if they commit to and then succeed in, exercising more or changing the food that they're consuming and so on, they will be rewarded with, it's to be determined because we're still working it out, but with vouchers off, for healthier, food, money off healthy food, or possibly for cinema tickets and so on and so on and so on. It's certainly something it's a version of what a number of insurance companies here and around the world have tried. And some governments, Singapore has done a lot in this space. They run these kind of massive competitions of, can different groups, different communities do more to, earn points and so on and so on. Various councils in the States have done similar. So we're very interested. We need to experiment, right? The fact is there's lots that we don't know in this space, and lots that is being learned in terms of kind of behavioral innovation. So it's not quite a tax rebate, but we're going to try to test out what types of benefits, if you like, people value, and critically, does it last? Because that's the bit we really don't know, right? When you stop or you dial it down, does the behaviour continue? So yeah, watch this space. That should launch in the spring, and we'll see what it tells us.
Yeah, thank you. And there is the question, the other, as we haven't mentioned it officially, although we've touched on it, the local government officers. Really, what some of us have seen has been the cutting of services. When public health competes with, more swings. Now, more swings for children may be very valuable, but improving public health provision and sanitation and those kinds of things is a conflict of interest. How are you going to protect the local budgets to do the this?
Yeah, the core clearly local government finances have clearly been under significant pressure. Right, and it's not, as I said, I'm not here to kind of defend the government on that wider position, remains very challenging. The public health grant, which obviously isn't the be all and end all of public health local spending, but is a very, very major part of it. The public health grant is ring fenced, so there are different people, different local authorities will use it in different ways, but it is ring fenced for public health, and they have to account for how it is spent on public health. And we have worked very, very, very hard to try to maintain it. There have, of course, been in previous years, reasonably, there have been cuts to the public health grant, and we've worked, very hard, not always successfully, but worked very, very hard to try to keep that budget there, keep it stable, and to maintain it. And the spending review did confirm, right, that we were going to be funded to broadly be able to do that. I think there's lots more that, lots of fantastic work that is done, but lots more that could be done to really make sure that within that context, there is, good shared learning between different areas on how they are maximising what they get from that grant, and how they're managing what, as I said, is, without question, a very, very difficult spending context for local government. It would be wrong of me to suggest otherwise.
Another question on a different angle is the question of whether climate change is part of your remit, as it's a major problem for the future health of the population. Have you any connection with that?
Yeah, it's a great question. So it's not so not directly, but it's kind of it's definitely on the list of areas. Well, to an extent, it's on everybody's remit, if that makes sense. So I don't think we are yet in a position to have worked through what it really means for the kind of work that we're trying to do. But it's absolutely kind of on the list of areas where both from a kind of need and an opportunity angle, if that makes sense. So I think there is some really interesting work, for example, that is going on, starting in transport, which can have benefits both ways, right? So how do we really push active travel, and so on and so on? And there are ways in which kind of part of the climate agenda can resonate with some of the people we want to reach in ways which some more traditional public health arguments have struggled to. So and similarly on air quality, which continues to be reasonably significant concern for much of the public health community. I think the focus and approach to climate change in its various manifestations gives kind of some new light, some new ways into some of these issues. So I think it's kind of on the to-do list, but not yet a kind of very well developed area of our work.
There is a question which has been bugging some people when the talk was originally announced, and when I originally told a distinguished colleague in America, he said, "Oh, is Britain going the route of America? Because inequalities is not allowed to be used as a term there, and now shifting to disparities." That was the one question. And the other is they're picking up an Americanism. And the other thing is that you are part of the Department of Health. What is your capacity to turn around to the Department of Health and tell them, well, actually, you're the ones that have got it wrong?
Okay, disparities and inequalities. So I'll be completely honest, like people have lots of different views on this. My view and the view of kind of the office's leadership and so on, we use them broadly interchangeably. Our Secretary of State came in and asked us to use when he was naming the entity, wanted to use the term disparities. It's a term that resonates with him, and he wanted his stamp on it, which is fair enough because he was our Secretary of State. But I don't, maybe I'm being naive. I haven't experienced anything which suggests to me that he means, or we mean something different to that materially than the range and depth of inequalities which we are, and I think should be focusing on. Certainly, I think the department is more focused on health inequalities and disparities now than it has been really for some time. And that's something certainly that this Secretary of State is pushing very, very hard and very, very seriously. So I don't want to say it doesn't matter, because I'm sure lots of things matter, and I'm sure there's lots more history and depth and complexity to the language than I fully appreciate. But in my experience of it, they mean the same thing, and we are using them in similar ways. Can I tell the department it's wrong? Yeah, that's what I do. Isn't that our job? I'm not quite sure. I suppose the question what we mean by the department. I mean, our job is to challenge our colleagues, challenge our ministers. We need to do so with good evidence. We need to challenge them with good alternatives. But yeah, that of course. I mean, that's our job. I suppose more importantly than telling us that it's wrong is to try to find a better way through, and to recognise our limitations. Right, I'm a civil servant. I serve the government of the day. My job is to try to make sure that our ministers and indeed other parts of government are given the best advice, the best information that we can give them, and then they make decisions and then we implement them. That's not always comfortable, but mostly it works pretty well. So yeah, I think we absolutely can be challenging, and certainly, you know, we are very, very conscious that in bringing this kind of work inside the department, we have to make sure that that doesn't come at the expense of speaking truth unto power, right? So we need the data to be able to speak for itself. The CMO's leadership is very, very important for that, right? He's clearly extremely able of speaking truth unto power, and helps to make sure that that there is good recognition of the evidence, of the facts, and then ultimately, as I say, the decisions of the ministers.
Right, and finally, some people have said that Sally Davis's memorial is the NIHR. Is the OHID what Chris Whitty would regard in 10 years' time as a suitable memorial?
I couldn't possibly comment. I mean, Chris is going to have many, 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 many things to, you know, things to be proud of, certainly. But yeah, I don't know. I hope that I hope the department is different over time because of this. And the reason that matters is not like, who cares about departments, right? But the reason that matters is because I hope that as a result of that, as I said, we can mainstream some of these issues, right? That it will become much, much, much more normal, common, frequent, that when we are talking about health spending, health prioritization, health delivery, that we it is intrinsic, it is part and parcel that we should talk about disparities or inequalities, that we should talk about health improvement, we talk about health and not just, you know, disease management, right? If we can do that with the CMO's help and the help of many others, then we'll be in we won't have solved all these problems, we won't have solved the causes of causes, but we will be better able to utilize the levers of government and of the health system to hopefully turn the tide on some of these challenges. So it's very early days, but hopefully we will get there.
Well, I think we've gone over time. We've had an enormous amount of interest in what you've got to tell us. And I think, I hope I speak for most people, that I feel a lot happier after hearing this than I was beforehand. And I'm also happy that you acknowledge that there are uncertainties around the area, which you're going to try and resolve and solve to the benefit of all. If I may, can we circulate your actual questions to the people who are here?
Great.
And say to them, if they want to respond, or they want to send us their responses to send to you, you'd be happy for us to do so.
That would be fantastic. Thank you.
Thank you very much, I think, on behalf of everybody who's heard tonight.
Great. Thank you very, very much. Really lovely to be with you all.
Thank you.